Hello everybody, my name is Ian McCall. Welcome to one of the videos from the Dermatopathology Made Simple series. Tonight we're going to look at desmoplastic melanoma. And there's nothing simple about desmoplastic melanoma. First of all, as it says here, it's a difficult melanoma to diagnose clinically. You sometimes can diagnose it best just by feeling it. You see a little bit of pigmentation on the surface, or a pinkish area, or perhaps even a white scarred area. But when you put your finger on, you feel the sclerosis in the dermis. So, as I say, it can be a pink, slightly keratotic nodule, or just a brown lenticle maligna-like lesion. And this latter presentation, the brown lenticle maligna-like presentation, that occurs because there's an overlying proliferation of atypical melanocytes in the basal layer. And it's diagnosed as an atypical lymphocytic proliferation or as lenticle maligna, especially if someone does a shave biopsy, because the shave biopsy may not take up, may not be deep enough to show the spindled cells of the desmoplastic melanoma, and may only show just this little area of atypical melanocytic hyperplasia or lenticle maligna. So watch for that. If you think you may have a desmoplastic melanoma, then you need to do an excisional or at least an incisional biopsy to give you the depth that the pathologist needs to examine this. We've said that in the deeper dermis there's this population of spindled melanocytes coursing in between the collagen bundles and eliciting a desmoplastic response with marked thickening of that collagen. Now this thickening of the collagen, this causes the white lines that can be seen dermatoscopically in some cases. And it also contributes to the white sclerotic areas that are seen clinically. Now we'll see some of this in the clinical pictures below when we come to these. And sometimes also when you look at a slide, you'll see these localized aggregates of lymphoid cells in the dermis. Almost looking like lymphoid follicles. But what it does is it alerts you to the presence of the atypical spindled melanocytes there. And these spindle melanocytes in desmoplastic melanoma, they also show the phenomenon of neurotropism. They seem to proliferate and extend around nerves. And this adds to the likelihood that they're going to be inadequately excised. Because clinically, you've got to take these lesions out probably with 2 centimeter margins, surgical margins. If you don't, you're going to find that they're going to recur. Let's have a little look at some of the images in this particular section. Okay, this lesion here is the desmoplastic melanoma. Slightly keratotic on the surface, pinkish more than anything else. Stick the dermatoscope on it, you can see the bit of keratin here, pink background, not really much in the way of a pigment network. And the close-up here shows some of the white lines. White lines here are part of that desmoplastic melanoma. There is a bit of pigment surrounding this. You'd need to see that in enlarged form to see if it's lines reticular or not. But often it's that combination of white lines, a bit of pink, and a little bit of brown in the lesion that should make you think that it might be a desmoplastic melanoma. Let's just look. This was another one here. Here again, a firm pinkish nodule on the back. Some of them can look more lenticle maligna-like, and we'll show you an example of one of those just in a minute. There's the dermatoscopic view again. There's the enlarged one here. So again, pink with some white lines. The white lines aren't as obvious here as they were in the previous one. Just a little bit of brown pigmentation there. So these are awfully difficult lesions to try and diagnose dermatoscopically as well. This, though, is another one. This one's courtesy of Con Pappas from the Scans blog. And you get several features here. First of all, you've got this lentiginous type, a lentigo-like pigmentation, and at the edge of it, you've got a white sclerotic area. This is your pigmentation here. This is your white structureless sclerotic area. And here there was a proliferation of atypical melanocytes at the basal layer. What are you going to see histologically? well, I really should have this enlarged, but take my word for it, there's a little proliferation there of atypical melanocytes, these little clear cells that you're seeing at the base of the epidermis here. But then you've got some lymphocytes here, and you've got spindle cells in amongst the collagen here. And if we look at that in a slightly enlarged view, sorry, let's go back to it. There you see it there. These are your little clear melanocytes, just a sprinkling of perhaps more atypical melanocytes along the basal area. No nests, nothing like that. And here, though, you've got sheets of these spindle cells in the dermis. Here you've got your inflammatory lymphocytic reaction. If you look closer around about, you'll see the spindle cells in amongst the pink collagen. And these are usually quite thick. Often desmoplastic melanomas, are 4 millimeters in thickness or so before they're actually picked up, before they're diagnosed as such. Here's another histological picture of a desmoplastic melanoma. You've got loss of the epidermis here because of ulceration in this particular lesion. Here you've got these swirling spindle cells here. It may look somewhat like, say, a dermatofibroma. In scars, usually the spindle cells are arranged horizontally. In other words, they're a much more structured arrangement of the spindle cells in a scar. But, a young scar, it can be difficult sometimes to exclude a desmoplastic melanoma. The pink you're seeing here is all the thick collagen. These are your spindle cells coursing in between them. I think they elicit part of a response, a collagenous response as well. This is another view of this particular case, and here you'll see here near the top of this lesion, you've got some nests of cells, superficial nests of melanoma. But as you go deeper down, the melanoma cells change into these spindled melanocytic cells, and they invade quite deeply. You can see the spindled shape of these lesions here, but it's good if you can see these cells. So this isn't maturing in depth, it's getting more immature with depth, more atypical with depth, and that's always a feature of melanoma. Here's another clinical. Again, this combination, a white sclerotic area, a pink area, and a little bit of brown superficial pigmentation here where you've got basal layer pigmentation. The pink vascular area, the white sclerotic area. And this case is courtesy of Jeff Keir, again from the Skin Cancer College of Australia and New Zealand's blog. When you look at this one dermatoscopically, there's your white sclerotic area. This is your pink area. There are some little grey dots in here as well. And you've got your darker peripheral network. You can see just part of the network just here. But gee, it's not much, is it? There isn't much in the way of white lines in this particular desmoplastic melanoma. But when you have a look at it histologically, here you can see just a few, there are some little nests of cells and some single melanocytes up here at the dermoepidermal junction, but mainly a lentiginous proliferation of atypical melanocytes. But there is a little bit of nesting here. So you can imagine if you did a shave biopsy through this and didn't pick up all of this, you'd get the wrong diagnosis from the pathologist. So that's why it's important to do an incisional biopsy in these lesions. And down here, all this pink material, there's the thick collagenous stroma in the deep dermis. And the bluish cells you're seeing here are the spindled melanocytes. If you would go down there with higher power, you'd see these spindled melanocytes in between the collagen bundles. It's sometimes useful to have a look at any nerves that you might see, because desmoplastic melanomas, I think somewhere in the region of about 50%, have a tendency to wrap themselves, the spindle cells will wrap themselves around nerve bundles, and they'll show this phenomenon of neurotropism. So that's always something to look at. Histopathologically, they sometimes divide desmoplastic melanomas into those that are purely desmoplastic and spindle cells, and those that are a bit mixed. But this is a bit more advanced, and I don't think it's necessary in skin cancer work to really understand that. The thing to understand is that there's often a superficial lentiginous component here, I think in 60 to 70% of cases, and you've got the spindled, deep spreading component of the desmoplastic melanoma that can go right down to the fat layers or below. So this is why these have to be taken out really with 2 centimeter margins, if you can do that, and watch for any features of neurotropism. Now we've said, as with any spindle cell tumor, that it sometimes can be very difficult for the pathologist to know that these are melanocytes, and they have to do some special stains. Now desmoplastic melanoma, as against other melanomas, isn't as good at picking up with these stains as some other forms of melanoma. But the S100 is usually positive in these, although I think in about 20% of cases the S100 may not be positive. And I think a P75 is another immunoperoxidase stain that's used. It I think shows some form of, I need to check up on it, is it some form of neural stain? Yeah, I think it's a nerve growth factor receptor NGFR stain. This is this P55 nerve stain. It does stain the cells in desmoplastic and neurotropic tumors, but it'll also stain other tumors of neural crest origin. But anyway, the thing to know is that usually the S100 will show up the desmoplastic melanoma, but some of the other stains won't. Your other differentials, of course, spindle-celled lesions might be a poorly differentiated SCC, but that'll usually show the cytokeratin markers. Dermatofibrosarcoma protuberans, again, clinically they're different, and they usually give a sort of storiform arrangement of the spindle cells. And a very hyperchromatic nuclei, but they can extend into the fat and fat septae as well. And scar tissue. If a lesion has previously been biopsied or had something done to it, then you can get scar tissue underneath, say, a recurrence of lentiginous proliferation, and that might be misdiagnosed as a desmoplastic melanoma. So, just to go over, I think we've got one more image to sort of show here. Yeah, this was just again the spindled melanocytes here in the dermis. These are eccrine glands, and these are thick collagen bundles. You should always, as I say, look for nerves and see if there's any spread around there. So, just to go over again the main features of a desmoplastic melanoma. These atypical melanocytes in the basal layer, or lentiginous proliferation, usually a wedge-shaped dermal infiltrate, a proliferation of spindle cells in between the collagen bundles. There's often very little or no cytoplasmic melanin. That's why, you know, these look pink. They don't look, or white. They don't look the brown color that you might, or blue color that you might expect with melanoma. That's deeper down here with melanin pigment in it. These things don't have a lot of melanin pigment in it, and you get that fibrotic dermal response. Perineural spread may occur, and this patchy lymphocytic infiltrate that you may see, alerting you to look more carefully at the cells in the area. So just to go back to a clinical again, desmoplastic melanoma, usually in sun-damaged skin, particularly in males, head, neck, and back, combination of sclerotic areas, pink areas, and a little bit of brown pigmentation, and feel it. If it feels firm, then consider that it might be a desmoplastic melanoma. And as I say, an incisional or an excisional biopsy rather than any type of shave biopsy of these lesions to give the pathologist a fighting chance of picking them up. The prognosis with desmoplastic melanoma, various studies seem to give different results. The consensus seems to be that it's much the same as any other melanoma of equivalent thickness, but the problem is it's often late before these are diagnosed, so they're often a lot thicker than other melanomas. They're not picked up quickly enough. So the desmoplastic melanoma, try and remember that picture: brown, pink, and white. And remember, it can be difficult dermatoscopically to diagnose it, and let your fingers do the talking as well. Thank you very much.